Welcome to Chest Pulse. I'm your host, Dr. Ashwin Basavaraj, Associate Professor of Medicine at NYU Grossman School of Medicine and System Chief of Pulmonary for New York City Health and Hospitals. Joining me today to discuss bronchiectasis exacerbations and management strategies is my friend and colleague, Dr. Charles Daley. Dr. Daley is Professor of Medicine and Chief of the Division of Mycobacterial and Respiratory Infections at National Jewish Health in Denver, Colorado, and he's an expert in the care of bronchiectasis and NTM. Dr. Daley, welcome to the program.
Thanks, Ashwin. It's great to be here with you.
So, Dr. Daley, there's a lot of excitement in bronchiectasis and bronchiectasis exacerbations in general, and we'll get into the new therapeutics that are in the pipeline for bronchiectasis exacerbations. But I think it's important to let the audience know what a bronchiectasis exacerbation is exactly and why it's important to recognize exacerbations. Can you let us know what a bronchiectasis exacerbation is?
Yeah, I mean, the simple answer is when our patients get sick. But there have been attempts to try to define what an exacerbation is, and although these definitions were actually put together initially for clinical trials, I think they can also be useful clinically. These were published previously by a working group of the ERS. And here's basically what they said is that a person has an exacerbation if they have a deterioration of 3 or more key symptoms in the previous 48 hours. And so things like cough, sputum production, sputum purulence, breathlessness, fatigue, hemoptysis, all the things that we ask patients about when they have bronchiectasis. But the final part of this definition is that the person is symptomatic enough that the clinician wants to treat them with an antibiotic. So often we'll ask patients, how many times in the past year have you had to take antibiotics? And that helps us kind of put them into a group of a frequent exacerbator, which could be 2 or 3 or more exacerbations in a year. And the reason that's important is because exacerbations are associated with some negative outcomes like worsening pulmonary function, worsening quality of life, and actually increased mortality. So I think it's a very important thing. And there are even predictors of who might exacerbate, like Pseudomonas infection. But one of the most important is just if you've had a previous exacerbation. That's actually a risk factor for exacerbating. So they're important. It's important for us as clinicians to try to keep track of this in our patients.
Yeah, and we know, it can be challenging to recognize bronchiectasis exacerbations, and oftentimes it can present with symptoms similar to what we see in COPD and asthma exacerbations. And why would you say it's important to try to differentiate between COPD, asthma, and bronchiectasis exacerbations?
Well, the treatment is going to be different, most likely. In someone who has asthma or COPD and they're exacerbating, this is someone that we may consider the use of corticosteroids, for example, and that's, one of the indications. We often do not need to do that in the setting of bronchiectasis. In the setting of bronchiectasis, really we're focusing more on airway clearance and treating the underlying infection. So I think the use of steroids is one of the things that really separates those to me.
Yeah, and it's really important, as you mentioned, with the use of steroids. We know that in patients with bronchiectasis, they oftentimes coexist with resistant organisms such as Pseudomonas, like you mentioned, and MRSA. But there's also non-tuberculous mycobacterial infection and NTM. And there's been, albeit small studies, but some data that supports the use of inhaled steroids that can actually worsen some of these infections, such as NTM. So we know that inhaled steroids is a mainstay of management, with asthma and can be used in patients with COPD. But if patients truly do not have asthma or COPD, and in fact are presenting with a cough or wheezing secondary to a bronchiectasis exacerbation, they may not benefit from steroids. And like you mentioned, they may benefit from other treatments, treating their infection or potentially, managing their bronchiectasis with other strategies. There can also be side effects with steroid use. With inhaled and oral steroid use, repeated use can lead to not only the risk for chronic infections, but osteoporosis, elevated blood sugars in patients who have diabetes. So we want to exercise caution when we use both inhaled steroids and oral steroids chronically. Now, there is a subset of patients with bronchiectasis where they may actually have some benefit with inhaled steroids, and that's patients that have predominantly eosinophilic inflammation that's driving their bronchiectasis. In those patients, and it's been shown that about 20% of patients with bronchiectasis do have a predominant eosinophilic phenotype. Those patients actually may benefit from inhaled corticosteroid use. So we want to try to identify those specific phenotypes to see if they do in fact benefit from inhaled steroids or not. For those just tuning in, you're listening to Chest Pulse. I'm your host, Dr. Ashwin Basavaraj, and today I'm speaking with Dr. Charles Daley about bronchiectasis exacerbations. So we spoke a little bit about what a bronchiectasis exacerbation is, but we're going to focus now on trying to prevent bronchiectasis exacerbations. We know the importance of identifying potential etiologies of bronchiectasis and focusing on airway clearance to help reduce the vicious vortex. But there are other strategies that can be used in certain patients with bronchiectasis exacerbations. One of those strategies is with the use of macrolide antibiotics. Although macrolides can be used for antimicrobial properties and targeting infections, there are also anti-inflammatory properties with the use of macrolides. There are 3 randomized controlled trials that were published in 2012 and 2013 that did show some clinical benefit with the use of chronic macrolides in the reduction of bronchiectasis exacerbations. Now, although it's not FDA approved, it may benefit certain patients that do have frequent exacerbations. Now, we want to advise caution with the use of chronic macrolides, specifically in patients with bronchiectasis, because of the chance of having underlying NTM infection with their bronchiectasis. We know that macrolides are a mainstay of management in patients with NTM infection and MAC. We want to avoid the use of macrolides chronically as monotherapy to prevent resistance from developing in patients with NTM. This is also important in the primary care population in the community, where we oftentimes use macrolides in the care of community-acquired pneumonia that develops in patients. So it's important that patients with a chronic cough and when they have the possibility of underlying NTM to check a CAT scan to see if they have bronchiectasis and to check AFB sputum cultures to see if they have underlying NTM. If they don't have NTM in their sputum cultures and there are no signs of potential NTM on imaging, chronic macrolides could be used for patients that do have frequent exacerbations. Now, Dr. Daley, we also know that inhaled antibiotics may be another option to help suppress bronchiectasis exacerbations. Can you talk to us a little bit about the benefits of inhaled antibiotics in this situation?
Yeah, I mean, we've used inhaled antibiotics in our patients with cystic fibrosis for many years, and we actually have FDA-approved products, 2 formulations of inhaled tobramycin and 1 of azathioprine. But we don't have anything approved for our patients with bronchiectasis who don't have CF. Although you and I have used these in those patients for many years. There was a very nice systematic review actually published in Chest last year that looked at the benefits of inhaled antibiotics in a non-CF bronchiectasis population. The main findings were what I think we see in practice, which is they can reduce the frequency of exacerbations. They can increase the time to the next exacerbation, and very important for our patients is that they improve quality of life. One thing that's been shown consistently is that bacterial loads are reduced. But I think the message about inhaled antibiotics is a little confusing because of a number of trials that have been done that have had mixed results in the non-CF population. Some positive, some negative. Things like inhaled ciprofloxacin, different formulations, 1 dry powder, 1 liposomal. It's just been difficult, I think, for people to interpret this, the results of some of these trials. Again, some are positive and some are negative. And that's what the systematic review, I think, is useful for, because it kind of puts it all together and sometimes picks up a signal that's not seen by a single trial. So I think in people who are exacerbating or have severe exacerbations, particularly if they're infected with Pseudomonas, this is a strategy that I often use, which is inhaled antibiotics.
Yeah, and I agree with you. It's, it is an option for our patients with frequent exacerbations. One of the challenges is trying to obtain the inhaled antibiotics. There can be, issues with, insurance coverage and trying to get some of these antibiotics approved. But if we can get these for our patients, they may have some benefit in trying to suppress their exacerbations. Now, finally, Dr. Daley, this is an exciting time in the field of bronchiectasis. We know that there's a lot of focus on bronchiectasis exacerbations and the potential for anti-inflammatory therapies that may help in the treatment of exacerbations. Can you talk about some of the novel agents that are being studied and have been studied already that may be available for use in the future?
Yeah, I agree with you. This is an incredibly exciting time in the field of bronchiectasis. One of the things that's emerged in recent years is the importance of neutrophilic inflammation in people with bronchiectasis. And most people with bronchiectasis have more neutrophilic as opposed to eosinophilic, although there is a subgroup that also has eosinophilic inflammation also. There's a class of drugs that I would say is one of the most promising. These are dipeptidylpeptidase 1 inhibitors. They decrease the maturation of neutrophils, which decreases serine proteases in the body. And this has now been shown with one of these drugs, brensocatib, in both phase 2 and phase 3 trials to decrease the rate of exacerbations, the time to the next exacerbation, but other positive outcomes, including improved quality of life. There are two other inhibitors that are in phase 2 and 3 trials. So this is, again, an exciting class, and all that's been published so far has been positive. There are other mechanisms of action that are being studied. And one is a novel phosphodiesterase 3 and 4 inhibitor, ensifentrine, which is approved for treatment of COPD and is now in a trial for bronchiectasis. Itepekimab is a monoclonal antibody that targets IL-33, also in trial. And last year, a trial completed with ARENA-1, which is basically inhaled glutathione, ascorbic acid, and some bicarb. And, it's amazing, but all of the trials that are being reported are positive. And so this is why I think we have so much excitement. We see drugs coming, and we expect brensocatib to be approved this summer.
That's great. Yeah, very exciting time for our patients with bronchiectasis. So a lot coming up in the pipeline in the future. So we covered a lot today, and I want to thank my guest, Dr. Charles Daley, for joining me in today's discussion. Dr. Daley, it was great speaking with you today.
You too, Ashwin.
Thanks for listening to Chest Pulse.